Specialty Stories, session number 126. Whether you're a pre-med or a medical student, you've answered the calling to become a physician. Soon you'll have to start deciding what type of medicine you'll want to practice. This podcast will tell you the stories of specialists from every field to give you the information to make sure you make the most informed decision possible when it comes to choosing your specialty. Welcome to Specialty Stories. My name is Dr. Ryan Gray, your host here every week, or almost every week, bringing you another great physician to share his or her story and how they got into their specialty. Now, my guest today is no different, Dr. Tim Brennan, and he shares his journey. It's kind of a circuitous journey to addiction medicine, starting off in internal medicine and then switching to pediatrics before finally realizing his passion for addiction medicine. We start that conversation with his journey to addiction medicine.
So I came a little bit late to pediatrics compared to most folks. I actually matched into a categorical medicine program when I was in medical school. My clinical rotations were a little bit out of whack because I went to Tulane during Hurricane Katrina. So the clinical experience was a little bit disjointed. Nevertheless, during my intern year in medicine, I actually decided to make a change into peds. So re-entered the match, rematched in pediatrics. And then during my pediatrics residency, started to sort of see more and more patients that were suffering primarily medical sequelae of what seemed to be behavioral health pathologies. And so that kind of piqued my interest in potentially going into child psychiatry. And then kind of the more I explored that interest of mine, felt like the more specific disorders I was particularly interested in were addiction disorders. So ended up going into addiction medicine right after my pediatrics residency.
What was it about addiction medicine that piqued your interest?
That's a good question. I feel like addiction medicine is the most medical of the psychiatric subspecialties, and it's the most psychiatric of the medical subspecialties. And so in that sense, I felt like it was very comfortable ground for a pediatrician that was interested in behavioral health. You've got kind of classic bread and butter withdrawal physiology. You've got an intersection of public health, public policy, and organizational medicine. And more often these days, you've got politics. Legislators are looking at the opioid crisis seriously for the first time in many decades. So in that sense, I found it to be a really rich crossroads that seemed to work for me. Perhaps most importantly for me at the time, the fellowships were only 1 year in duration compared to the typical pediatric subspecialty fellowships, which were 3 years in duration. Mm-hmm. And so it seemed like a fairly benign value proposition. So I dipped my toe in, and really the rest is history. I've been in the field ever since.
Yeah. So explain the journey for you. So you said you started the categorical medicine program, switched to pediatrics, went into addiction medicine. Are you certified or board certified? Have any training in the psychiatry aspect of that as well?
Yeah. So I boarded in pediatrics through the American Board of Pediatrics, and then also boarded in addiction medicine through the American Board of Preventive Medicine. And so addiction medicine is a subspecialty of ABPM, American Board of Preventive Medicine, and that's who we all get our board certification from. So that being said, psychiatrists paved the way. And so I count many psychiatrists among my colleagues. I'm on faculty within the Department of Psychiatry in my day job. And so while I don't identify myself as a psychiatrist, I'm certainly mistakenly identified as a psychiatrist by like the lay public, even patients, sometimes colleagues. And I'll, of course, politely correct them and not want to masquerade as them. But it's a field with a lot of overlap.
Yeah, definitely. Which is a question that kind kind of leads me to is, do you think, because the last guest who I had on that was doing addiction medicine went and got her psychiatry training as well. Do you think as an addiction medicine specialist, it is quote unquote better to have more psychiatry knowledge, or do you think it's just something you learn as you go through?
I mean, I think it would be unusual for an addiction medicine physician to not be psychologically minded. I think you'd struggle to find addiction medicine physicians who weren't already interested in psychiatry and hopefully adept at psychiatry. So I don't think any addiction medicine physician should be practicing if they don't have a real appreciation and affinity for general kind of bread and butter psychiatry, treating depression, anxiety, and so on. That being said, I don't think an addiction medicine physician needs to be facile at treating severe psychotic disorders, severe mood disorders, or severe personality disorders. We're very comfortable leaving that diagnosis and treatment to our psychiatric colleagues. So I think having the extra skill set in psychiatry can be synergistic. I don't think it's an absolute requirement, and certainly know many addiction medicine physicians that are very comfortable taking care of general psychiatry and don't need to have done that actual residency.
Okay, makes sense. What trait do you think leads to someone being a good addiction medicine specialist?
Yeah, so first and foremost, I think empathy comes to mind. We have the privilege of taking care of patients who are suffering from a horrible disease. Many of us grew up learning about the stigma of addiction from our friends, family, societies that we grew up in. And so many of us were raised to think negatively of people who suffer from addiction. So first and foremost, a physician who's going to be around those patients needs to be empathic and understanding that this is not a volitional disease. This is a disease like any other. I think, second to that, this is a medical specialty like any other, and we are evidence-based. And for all too long, addiction treatment was provided in a non-evidence-based manner. So physicians are admittedly very late to the addiction treatment world, but we need to bring our own unique skills, that is a foundation in science and a tradition of peer review, to the treatment that we're providing.
Yeah. Okay. What other specialties? You mentioned that you went into the categorical medicine program first. What was it that kind of led you that path first before realizing that pediatrics was where you wanted to go?
I don't think it was the most informed decision in retrospect. I knew I didn't want to be a surgeon.
Yep.
And I knew that while I had an interest in psychiatry, I felt like it was sufficiently far removed from the sort of traditional medicine skills that I had really been honing since pre-medical requirements, that I felt like I wanted to at least practice, for lack of a better term, regular medicine of some sort. So internal medicine is sort of a catch-all, if you will. So went into it thinking probably a bit diluted in retrospect, thinking that I would be a primary care doctor and have a panel of patients and sort of progress with them through their lives. And it became very clear very quickly to me that the modern internist, if you will, is really in a lot of ways a geriatric specialist, and oftentimes finding themselves taking care of people right at the end of their lives, whatever age they are. And that didn't really appeal to me.
Yeah. For a student who maybe doesn't completely understand addiction medicine and the types of patients you're seeing, can you explain the types of patients that you're seeing, and then given that you're a pediatrician, how that plays from a pediatric role as well?
Sure. So simply stated, the addiction medicine physician takes care of all patients. I have the privilege of taking care of people from across the age span, from across the socioeconomic spectrum, and really any other demographic that you can imagine. I consider that a real attribute of our field, because addiction has so many sequelae in psychiatric and medical disease, we of course end up interacting with specialists and subspecialists in a variety of fields. It's not uncommon for me in a typical day to encounter oncologists, gynecologists, otolaryngologists, dermatologists, infectious disease specialists, and so on. And so in that sense, I feel very much a part of the modern medical system. And like I said, my patients can come from a really wide variety of backgrounds. The truth about addiction is that it really knows no bounds, right? It affects all of us as human beings. And so in that sense, I see that heterogeneity reflected in my patient panel.
And then from a pediatric perspective, how young patients would a pediatric addiction medicine specialist see?
Well, tragically, addiction as a disease has been creeping earlier and earlier into our lifespans. Unfortunately, kids as young as 10, 11, 12 years old are experimenting with drugs. And so I've interacted with young children in that age group. More typically, it's adolescents, particularly folks in the young adult phase or emerging adult phase of their life, typically 15 to 25-year-olds. And of course, situations change depending on what age the patient is. An 18-year-old adolescent is going to have fundamentally different things going on in their life than a 13-year-old.
Mm-hmm. And then I think a lot of students listening to this will think addiction and think drugs and alcohol. What about food addiction and other addictions in that area?
It's a good question, Ryan. At the moment, addiction medicine is confined to the addictions that you would find in the DSM-5. That is to say, addictions that have been codified in DSM-5 and addictions that can be reimbursed by a third-party payer, primarily, say, Medicaid, Medicare. Food addictions, sex addictions, internet addictions, if you will, reside in, or a better term for that is, of course, behavioral addictions. For the most part, those reside in the section of DSM-5, which is our psychiatric manual, in a section that needs more research. Now, that can be where diseases reside before they're codified and thought of as actual diseases. But for the most part, the modern addiction medicine physician is not interacting with them unless they're in a sort of private practice environment where they're not billing a third-party payer. So I'm not suggesting that some people don't suffer from food addiction or gambling disorders or sexual compulsions, even sexual addiction for that matter, but it's not something that the typical addiction medicine physician is encountering in any sort of widespread capacity at the moment.
Yeah, makes sense. Do you have a typical day? And if so, what does that look like?
I do not. The nature of addiction medicine is so hybridized, if you look around the country, that we have very, very different career tracks. For one, we're a field that's still in our infancy. And so in that sense, it's kind of hard to find archetypes like you would see maybe in cardiology or gastroenterology, where you can sort of predict what a physician's day or life is going to look like in different phases of their career. It's not uncommon for me to make rounds on our inpatient detoxification and rehabilitation unit, followed by seeing a few consults in the hospital or perhaps the emergency department. I oftentimes will float through our opioid treatment program where people are coming to get direct daily observed methadone or buprenorphine, and oftentimes find myself in group meetings at our residential halfway house. So that is to say, my days are very different, very distinct, which to me has great appeal.
Do you feel like you have enough time for life outside of the hospital?
I do. I think fundamentally addiction is a specialty that follows business hours for the most part. Now, of course, there is some after hours calls, there is some weekend calls, but not like a trauma surgeon would have, not like a critical care physician would have. So we're certainly accountable and reachable by our patients, but this is typically a Monday through Friday career for most addiction physicians.
How competitive is it?
compared to the surgical specialties, it is less competitive. What we've seen, though, in the last 6 to 12 months is really an explosion of interest from residents for our fellowship programs. So going back 4 or 5 years, a lot of the fellowship programs did not have that many applicants to choose from. Now, all of our fellowship programs, for the most part, are inundated with applications. So I think most of that is interest in the opioid crisis. We've seen it on the front pages of newspapers and magazines. And so the modern medical resident reads those same papers and is aware of what's going on. So I don't think things are dissimilar in our field to what went on in HIV medicine. Once HIV exploded, you suddenly saw a lot more competition in getting into the field. And that's really a good thing for our field.
Yeah, definitely. For the osteopathic medical student listening to this, do you see any negative bias towards DOs in the field?
I do not. In fact, addiction medicine has been a field that's been richly populated by osteopathic physicians really since our origin. Many of the leaders in addiction medicine have been osteopaths. I count many of them among my colleagues. So I think certainly compared to other fields, this is a lot more welcoming. I'm not really aware of any bias that has gone on about the osteopaths. In fact, there's a pretty rich tradition of addiction medicine within the Osteopathic Association as well. So I think in that sense, it's a pretty welcoming field.
Yeah. Once you become an addiction medicine specialist, are there opportunities for further training, whether formal or informal, to just do opioids or just do alcohol, things like that?
There are. Inevitably, people pigeonhole and subspecialize. For example, somebody who comes into addiction medicine from emergency medicine may find themselves practicing kind of more of a toxicology-based practice, right? They might have a position in a health system where they're called upon to opine about various overdoses in the community, poisonings, and so on. Likewise, a psychiatrist who does an addiction medicine fellowship might find themselves working in a much different capacity. So we don't yet have kind of subspecialty fellowships within addiction, but there are certainly folks who specialize within addiction. One of the things that's important to point out is that addiction medicine fellowships are not just teaching people about the opioid crisis. The opioid crisis, of course, is our current addiction crisis in America, but we've had a tobacco and alcohol problem for many decades, and inevitably there will be another crisis around the corner. So the goal of the addiction medicine fellowships is to equip a workforce with a skill set that's transferable to whatever that next crisis is. In fact, many of us think that once we finally get our heads around the opioid crisis as a country, there will inevitably have been the sort of dawn of a new crisis. And so we can perhaps use the opioid crisis to get ourselves equipped.
What do you wish the future primary care physician listening to this episode knows about what you do day in and day out to help you and help your patients and their patients?
Sure. So I have a thesis, and that is that the average primary care physician doesn't know any addiction medicine physicians. The average primary care physician, she or he may not even know that addiction medicine exists. And so that's on people like me to spread the word around. I would contrast our field with, say, endocrinology. The average primary care physician probably knows a few friendly endocrinologists and her or his network where they can call on those endocrinologists for curbside questions, routine patient referrals, or for that matter, complex patient referrals. My goal, my wish for our field is that we have graduated enough fellows, credentialed enough physicians such that the average primary care physician, when they are presented with a difficult addiction question, knows exactly who to call and who they can rely on in their community to refer patients for evidence-based medical care or evidence-based curbside consultation. That's the goal, and I feel like we shouldn't stop anywhere short of that.
Yeah. Do you see any special opportunities outside of clinical medicine for addiction medicine specialists? I think you'd mentioned a lot of policy and politics and stuff. So maybe thinking about that.
I do. I think it's well, for example, let's say you and I went to a busy intersection. I'm actually here in New York City. So if you and I went down to Times Square right now and we interviewed 100 patients and we asked all 100 of them what their opinions were on non-Hodgkin's lymphoma, I would guess that the overwhelming majority, in fact, perhaps all of them would say, I don't have an opinion. Ask the oncologist what she thinks. But if we went to Times Square on a different day and we interviewed another 100 people and asked them what their opinion was on heroin addiction, unfortunately, perhaps a majority of them, in fact, maybe all of them, might have a opinion. That's very unique in medicine, right? This is a strange disease that, for whatever reason, even people with no medical training think they know how to treat it. They think they know how to diagnose it. They think they know how to treat it. And they think they know how it'll get better or worse. So in that sense, this is a field with a lot of rich overlaps with the rest of society. Likewise, legislators, law enforcement, and so on, they come up against addiction in their domains. And so as they're writing laws, as they're prosecuting cases, as they are kind of creating public policy, I think that's a real opportunity for physicians in the field to impact that work and speak from a place of science, so as to improve the public health and try to decrease stigma.
What's the biggest misconception or myth around addiction medicine?
Probably that the patients don't get better. It is a great privilege to take care of these patients. And unfortunately, when I tell people that I do addiction medicine, even other colleagues, it's often met with an eye roll or a sort of offhanded remark about how difficult, quote, those people are to take care of. And really what that speaks to is that physicians, nurse practitioners, PAs, they're oftentimes interacting with addiction sequelae among patients who don't want treatment, right? They're taking care of patients in their clinic who might be asking for a little bit too much or too frequent pain medicine. They might be taking care of patients in the emergency department or on the wards who are not interested in addiction referrals. And I would contrast that with the patients that I take care of. Patients fundamentally come to me because they want care. And so oftentimes that same patient may rub providers very different ways as they migrate through the health system. And so my experience is that people, when they are interested in getting sober, it's really a privilege to take care of them. And if you can be with them on that journey, they really do get better. So when we talk about breaking up myths, I think that's pretty much the prime one. And so I oftentimes invite colleagues from other fields to come spend some time with us or really re-engage with patients once they've gotten sober, because it's really dramatic, some of the changes that we see.
What do you know now that you wish you knew before going into addiction medicine?
Oh my gosh. I guess I didn't realize how much medicine I'd still be practicing. That's probably a vague term, but when I was going into addiction, I thought, well, all I'll be doing is addiction. That's not the case. I'm still managing hypertension. I'm still managing diabetes. I'm still treating people for infections. And so in that sense, I had a little bit of trepidation because I thought, well, I'm kind of giving up my primary field, moving into addiction medicine. And really, you're not giving up your primary field. You're still going to be practicing medicine. People with addiction have all of the same problems that people without addiction have. And so that's been really a good thing.
Do you turn into, as patients are coming to you and struggling with their addictions, do you turn into their primary care provider a lot of times? Oftentimes, yes, when they're with us. That being said, we're actually careful
to not do this in the long term, there's been some myth making in addiction that's been perpetuated by Hollywood in this country. And that is that addiction is best treated in a one-off residential setting, typically a bucolic setting with lots of green grass and maybe some horses to play with and so on. And there's this popular narrative that people with an addiction problem, quote, go away to rehab and they come home cured. Now, we know from decades of experience, much like cancer, for example, that that's not the case, right? You can't, unfortunately, simply excise a tumor and forget about it for the rest of your life. It oftentimes involves longitudinal care. Well, the same is true for addiction. And so I very much feel the need to kind of deconstruct that a bit and make people aware that they are going to receive longitudinal care. Likewise, when patients transition away from us, it's important to realize that they're not going to necessarily be at our center for the rest of their lives. And so very early on in their treatment, we're trying to plug people into primary care in their communities so that they can have that follow-up moving forward. It's not uncommon for people to come to us having neglected their preventive medicine needs for a long time, right? A lot of people come to us and we realize they need pap smears and mammograms and colonoscopies. So of course we help them set that up, but we're not looking to replace the primary care physician in their health landscape.
Yeah. What do you like the most about addiction medicine?
Well, this is going to sound crazy, but I never thought I would be thanked so much going into a field. I think people are really grateful if you can provide them some dignity and some respect, and help them get sober. And so in that sense, I had no idea that people would be so grateful. It's almost a shame that they are so grateful, because I think in a way it speaks to how stigmatized and maybe disillusioned they've been with their healthcare before they've gotten to addiction physicians. So it feels good. I love being thanked. But part of me wishes they weren't surprised that we treated them with such respect.
What do you like the least?
The third-party payer. I waste hours out of my week doing quote unquote prior authorizations. Most of the time I'm talking to a robot that's not even good at being a robot. When I do speak to a person, they're reading a script. They're always shocked that they're talking to a physician. I think they expect a secretary or administrator. It'd still be a waste of their time also. But that really is frustrating. That being said, I'm going to continue to get on the call because the patient needs the medicine. It's just a shame we have to jump through those hoops.
Yeah. If you had to do it all over again, would you still be an addiction medicine specialist?
Absolutely. And in fact, I try to tell as many medical students as I can. I view them as kind of undifferentiated stem cells. I've been thrilled with this field. I think it's a wonderful field. I'm happy to come into work each day. Like any other part of medicine, some of our patients get better. Like any other part of medicine, some of our patients get worse. And so that's part of doctoring, that's part of healthcare. But it's an absolute privilege to take care of these patients. They've been maligned and stigmatized by the rest of society. And so I feel like it's a very compelling pursuit.
Something I asked the last addiction medicine specialist, specific to addiction medicine, and a very common question that I think potentially could come up in a medical school interview for pre-meds that are still applying. Portugal had a very big thing many years ago, decriminalizing all of their drugs with really good results. And it's always a question, do we do that here? What is your thought on decriminalizing drugs in this country?
Yeah, it's a great question. I guess I would start off by saying we are not Portugal. We are not Scandinavia. We don't have their oftentimes very homogeneous electorates. But with that being said, I know for certain I don't want any of my patients in jail for something that I consider to be a medical disease, especially a medical disease that is not their fault. And so I'm really glad you asked the question. and asked about decriminalization and not simply legalization of drugs. And in that sense, I think decriminalization, as evidenced by the Portuguese experience and some other experiences around the world, has shown that that's a really important middle ground between legalization and maybe an experience like Singapore, for example, where you've got more draconian laws in place. So I'd love to see the U.S. Move in that direction. I think we're sort of tiptoeing there in certain states around the country. I'd like to see a little bit more of it. That being said, I think the sheer illegality of drugs is oftentimes enough of a roadblock to prevent use. So the pediatrician in me is actually very mindful that if we somehow decriminalize all drugs, will we sort of accidentally make drugs a bit more appealing to a typical youngster? And so that does give me some pause. I'd like to see us move a little bit quicker than we're moving now, but still be rather judicious on our way there.
Well, we here in Colorado are trying to do our part with the decriminalization of mushrooms recently. So
yeah,
we're getting there.
Yeah, and the Colorado, we could talk for another hour about Colorado's experience with cannabis. I think I get very uncomfortable as a physician when I feel like people are forcing me to use my MD in a way that I wasn't taught. And so in that sense, prescribing cannabis, prescribing mushrooms makes me very uncertain because I never was able to learn what's in those products.
You didn't have that course in med school?
I did not. No, not at my school. And so I feel a bit like a fraud if somebody asks me to write them for a prescription for cannabis. And so in that sense, I think, the decriminalization, legalization, medical usage of, say, cannabis, a lot of that has gotten really conflated into one issue. And that's a shame because a lot of these are nuanced issues with very specific realities in each of their lanes.
I was trying to remember. I thought I heard at some point there was at least one institution. There's very few, obviously, because of the classification of marijuana by the DEA. But I thought Tulane was an institution that had clearance to do some research and do some testing. Maybe I'm wrong.
Yeah, you may be. In fact, it is possible. It just takes forever. Yeah. And so if we can change the schedule, I think we can figure out once and for all what is in this plant, what exact components of it work, what exact components of it do not work. And much like an aspirin, decide the exact route, the exact duration, and the exact frequency, such that when we send people to the pharmacy, we send them with as much conviction as we would for any other product. I fear that if we don't unschedule the product, we're never going to be able to do that research at the scale that you'd see with any other therapeutic agent.
Definitely. For the pre-med medical student or even resident listening to this, thinking about addiction medicine, what final words of wisdom would you have for them?
I guess I would go back to my my words from a few minutes ago, and that is that you're not giving up your primary field. Addiction medicine is a field full of internists, family medicine docs, OBs, surgeons, radiologists, anesthesiologists, psychiatrists, pediatricians. I mean, you name it, those folks have entered into our field. And so I think sometimes when people are thinking of a subspecialty, they'll oftentimes think, well, I've done all this work. It feels like I'm kind of throwing it in the garbage to move into this small little niche field. That's really not the case in addiction medicine. You're still going to be practicing your primary specialty. There's a lot of really hybridized career paths out there, particularly in addiction medicine. And so I think if you're at all interested, I would encourage you to kind of dip your toes a little bit deeper into the water, reach out to a fellowship director. We've got over 70 addiction medicine fellowships in the country right now. All of us are a tight-knit, friendly group. This is really a passion project of ours. And so in that sense, I would encourage them to look into it and not be dissuaded thinking that they're somehow going to give up their primary specialty, because they're really not.
All right, there you have it. Again, Dr. Timothy Brennan, an addiction medicine specialist, pediatric trained at Mount Sinai, who's been out of training now for 7 years. Hopefully this has given you some insight into addiction medicine, into what Dr. Brennan says is an amazing specialty that everyone should look into. And hopefully you can find a physician to shadow if it is something that you are interested in. I hope you have a great week. We'll see you next time here on Specialty Stories.
This is MedEd Media.